Our partners set their own sexual and reproductive health and rights advocacy agendas and track and alert stakeholders of current and emerging threats and opportunities. They also are implementing critical programs that support an enabling environment for universal sexual and reproductive health and rights in their countries and communities. PAI works side by side with funded partners, providing nearly $7 million in yearly funding, advocacy support, and strategic guidance to simplify sexual and reproductive health and rights calls to action and hold policymakers accountable.
UHC guarantees that people are able to afford the health services they need without the risk of financial hardship. Putting these two together, UHC essentially creates the enabling policy environment as well as the financing mechanism to ensure that individuals and communities do not end up impoverished as a result of accessing health services.
We had consultative meetings with the member of county assemblies. We had never reached that far. We brought them in a conference room and consulted and made sure that they even understood the components of UHC. Because initially in this county, when you are talking of UHC, there are two things that came to their mind. One was NHIF, and the other one was drugs in the hospitals. It's like you'd hear people asking you in Swahili, kuna madawa, are there drugs? So they didn't see the other components. So when we brought the MCAs, because these are the people who engage their communities, that was a big win. And they even said this is the first time that people have actually appreciated the role they play. And from there, they became our champions. For the first time again, Kisumu County allocated 20 million. Although it's not adequate, but it's the beginning. The first time that we have budget allocation for family planning. The county came up with Marwa. Marwa is ours. It's not national, it's not the national health insurance, it is Kisumu specific. And it was customized to meet the needs of the community. It's a partnership, county government and NHIF and other partners that we work with very closely to ensure that the quality aspect is addressed. So it all came together, and the county government is currently paying for those who cannot get NHIF. So they have their Marwa card. When you have that card, you are able to now access the services. And the uniqueness of Marwa is the first insurance cover that also has the preventive component, including family planning.
I remember after passing the Kisumu County Health Act, which allowed us to create a fund where we can have a solidarity fund for serving indigent populations, we had to do a regulation to this effect so that it can allow the county government to create an account for this fund. When we were creating this account, the county did not have that much money to put into this fund. I think we co-contributed. We had a partner who contributed some money, and the county brought in some money so that we could start a fund. That social security fund, coupled with the facility improvement fund, will really help make sure that the services delivery at the health facility are really improved, because we'll have money at the facility to replenish all the stocks of supplies that we think would be needed for service delivery.
Marwa health financing, to me, should be sustained going forward so that the diligence should be able to now get accessible quality services. We want to make sure that whatever services that our community members, clients access are actually of quality.
Pathways Policy Institute got a grant from PAI to support the Universal Health Coverage SMART project. We've been able to engage different opinion leaders and decision makers in terms of budget advocacy. We've engaged CSOs within Laikipia County in the same conversations, been able to do trainings for youth champions as well as CSOs who are in the reproductive health space. This has really helped us because we've been able to capacity build a very big number of people and also engage the budget committees of health and also education, because the issues around teenage pregnancies and women not getting access to reproductive health services has been an issue in Laikipia County. Through the project, the number one issue that we were trying to solve was to have a budget specifically for family planning, which I'm glad through the whole process, through writing memos and engaging the leaders, now Laikipia County has a specific budget for family planning. And also the issues on commodity securities and all that, we've been able to help the CSOs and youth serving organization to be part of this conversation, participate in public participation, ensure that the government officials give us are accountable for the amounts that have been disbursed. So now we have a family planning budget, so that is a win for us. And also the knowledge that the youth champions and the CSOs have at the moment, they can write memos and submit the memos by themselves. So we are glad that the number of people who have the knowledge is increasing gradually. Now we have a budget line for family planning. Now we are trying to ensure that it is increased. And that's why we did a study, an out-of-pocket expenditure study, to also know how much women are spending in terms of getting the services. So this also helps if you go with the findings to the county and you tell them with evidence from Kenya Information Health Systems, then they are able to reason with facts on the table. So now we are trying to ensure that the budget has been increased. Also the fact that from that study we were able to know how much a woman spends, and that also helps us to sort of convince and sensitize the community to uptake the healthcare cover. Because from that study we found out that a woman spends 200 shillings in getting FP services. And if they get the UHC, the NHIF card, which is 500 shillings for 1 month and will cover the whole household, it makes economical sense.
We are currently at 64%. Yes, UHC cover in Laikipia, and that is under the NHIF cover. And what we've seen, actually, we've been pleasantly surprised that people are willingly taking up health insurance. Those who are unable to do so are covered under the indigent program, and they're paid for the premium by the county government.
We did an orientation with key stakeholders to sensitize them on what was currently going on. So we had an opportunity that we saw that if we engage in the early stages of the benefits package process which was undertaken, we were able to ensure that stakeholders actually are able to input in the benefits package, and also to have the National Health Insurance Council to budget or include family planning services in the benefits package. So for us, our win was that all the methods of family planning methods were actually included, apart from the permanent methods. You know, so that's something that we so there's no vasectomy, there's no tubal ligation. Those two are actually not in the package, so it's something that we are working on. We were not able to get very convincing reasons on why they did not actually include them, but I must mention that we are quite excited and happy that all the other methods are there. You know, that's a beginning, and for us that's something that as a collective, as a coalition, that we worked towards to ensure that methods are actually embedded in the benefits package. So right now, our advocacy is to ensure that key stakeholders are involved in all the processes that are going on. Currently, Zambia is developing the National Health Plan, which will run between 2022 to 2026. Okay, so that's a plan. That's where we want to see that all these methods, including the benefits package issues, are actually embedded. Then we'll be talking about family planning being a national priority. We needed to convince the ministry in terms of health financing on why it was important to actually have family planning in the benefits package. How does it benefit the country in terms of economy?
We're advocating for health care, universal coverage, health and treatment, but as well as this very important element of reproductive health and family planning information and services, which is the key and the catapult to development of our nations. So that was a great success. We got it in there. Even if the bill was passed, not yet assented to, wherever it passes, and it's about to be, there will be those things that we worked for. The second, great win that we have is that this bill was passed by Parliament and we celebrated. So our intention was to have Parliament of Uganda pass a bill for national health insurance, which includes family planning and reproductive health. And this was done. The President hesitated and did not assent and has sent it back with comments. And this will be worked on. And very soon we believe this will happen. The other win, a third win that I am very proud of is that we have got now a sensitized leadership of the importance of family planning, not just as a health issue, but a development issue.
We want to make sure that we continue to do our work in advocating for the passing of health insurance scheme into law so that we bring everyone on board, make sure that whoever needs to contribute to that, he contributes. Whoever needs to access the health services, to access it wherever a person can find it, so that everyone's health is taken care of.
In 2017 to the end of 2018, Mary Stopes and its donors, DFID and others, decided to support the NHIA and Ghana Health Service to pilot the inclusion of family planning on the benefit package. And the pilot meant that selecting a number of districts where they will ask the women in these districts to go for family planning services once they have the NHIA card and will not have to pay. And then the NHIA or the facilities will then process the claims of these family planning services that they've provided to insured women to the NHIA for them to be reimbursed. And once that claim total is known, the NHIA will forward that total amount to Mary Stopes, and the payment was made to NHIA. And so we needed to think through how do we implement such a pilot, such that once the pilot is over, NHIA, Ghana Health Service, the ministry, and the government will accept and own it, and then roll it out countrywide, because the pilot was only done for about 7 districts, 7 out of the 275 districts or so. And so initially we needed to start advocacy-wise, how do we approach this? So 2 things was very key. First was consensus building on what the pilot was all about. engagement at the very early stages, at the very national level. So the Ministry of Health, the Uganda Health Service, the National Health Insurance Authority were the main advocacy targets. And so the pilot proposal was discussed with all of these organizations and was sent to the ministry actually for approval. And so the ministry approved it at the early parts of 2018 and mandated that we have series of consultations with the Ghana Health Service and the NHIA to make sure that they buy into whatever is it that we wanted to do. So that was at the national level. And then at the regional level, the regions in which these districts that we selected were, we also needed to ensure that we had a series of engagement with them. So the 7 districts were in 4 regions. And so we held regional consultation meetings with all the regional directors of health services, the National Health Insurance Authority regional managers, and made sure that they understood what we wanted to do and the processes, and they made inputs. And then we also went down to the districts that the pilots were going to be implemented. Again, the Ghana Health Service district directors of health services and the NHIA district managers were also consulted for them to make an input. So what we came out with as the pilot proposal was something that everybody understood. The implementation processes and all of that were understood by all at that level.
We were able to get the government institutions, the Ghana Health Service, the National Health Insurance Authority to take the lead. And so we facilitate meetings, we facilitate programs, we facilitate technical groups, but they were the ones leading. It was their ideas, it was their strategies on how to do it best.
We have found a way to get the public interested in what is happening in the health space, and that is mainly because of civil society. So the initial benefit package, obviously different lobby groups decided what is in there, but since then we keep trying to expand the package, and it's often because of civil society working with us to look at the data and how best we can incorporate it without bankrupting the scheme, but also bringing benefit to the people. So it's really quite a good partnership. They tend to do a lot of the advocacy and engagement with the people at the district level, because our scheme is really from the district and community up. So when they work down there, we begin to collate all the information and know how best to add a particular benefit or deceit.
Initially, we were not aware of the contraceptive methods, and therefore we were not able to do proper spacing of our families. When we were incorporated in this project, we came to learn that spacing is crucial, and we adopted this system of family planning. I would also urge our community to engage with our male counterparts in this sensitive issue in order to bring change in our society.
So with this thought, we implemented a project in these 5 districts where we are engaging with young men and boys of reproductive age, and we are trying to sensitize them by raising the awareness around sexual and reproductive health and rights.
The men must arise and embrace these family planning processes. And since we are all equal, we should all participate in this process, because the women in this country are burdened with so many things in the society.
The project also helped us to connect with different health workers who held a series of discussions with us on family planning and women health, which ultimately helped us to get access to contraceptive methods and resources.
We are trying to create local advocates in the form of women and men and girls, all the three constituencies. So these constituencies are encouraged to engage in the community-based monitoring process. Through these community-based monitoring, there are two benefit. These constituencies are having the ownership of while monitoring the services, and they are generating evidences. And these evidences are compiled in form of report, and these reports are being shared individually with the concerned official and publicly, means through dialogue, block level and district level dialogues. We are sharing these gaps and we are seeking their commitment, the commitment from the officials. So now the advocacy is more in form of, means the voices are from the community.
Sexual and reproductive health is more than a hope. It is a human right, and it is central to progress. But for far too many people, these rights remain out of reach. To achieve our Vision 2025 goals, we need many more voices to join us and contribute to an expanded ecosystem of advocates who are propelling global sexual and reproductive health and rights.
Our efforts in laying the groundwork in UHC and PHC are yielding positive results. And our hope is that with your guidance and support, we will strengthen the foundation of these efforts by 1. Increasing and diversifying our funding pool to include less restricted and longer-term investment that give us more room to engage a broader set of civil society partners. And 2. Continuing to develop clear advocacy and accountability strategies that speak to the realities of our partners' countries and communities and drive the greater global agenda on expanding SRHR programs and services.